Okay, great. So welcome. Because we're doing this on Zoom, I can open up multiple windows and have the questions in front of me and the articles and the readings. So that just makes life easier for me. I'm trying to think. Oh, so I've met with most of you. I have topics for everybody. If you haven't submitted it into Moodle, please do. And some of you have submitted it in Moodle, but I need to narrow it down with you. I spoke to a couple of people today, even just talking about how to make it narrow it down. And the key to narrowing it down is it just makes your life a lot easier. If you choose a broad topic, it's a nightmare. I mean, there's again, textbooks and libraries written a lot on a lot of these very interesting topics, but it just makes it impossible to come up with something meaningful to say in 10 or 12 pages. And again, I want some kind of specific prevention, intervention, or recommendations to come out of the paper. Always remember, almost everybody submitted their questions from last week. I'm still waiting for one person from the first week. Please submit those because it's 40% of your grade, and class participation is 15% of your grade. So very important to do that, and then the paper will be the rest. I've talked to most people. I don't think, and you guys, you can do by show of hands, I don't think I've talked to anybody who says it takes 3 hours to do the readings and answer the questions. I've heard as little as 45 minutes to maybe up to 2 hours. Is anybody spending more than 2 hours on the reading and answering the handful of questions I send out? Okay, so what that means is you should have minimum 5 hours to do a Google search of your topic, read some of the materials in there, narrow down your focus, and create a bibliography. So why don't we just go around and we can talk about, today the focus is going to be some nutrition stuff and gun control. We might even talk about police violence, since that's just such a hot topic right now and gives me waves of nausea every time I think about it. But anyway, the gun control is not far behind. And then the nutrition is just part of social determinants of health and how important it is and what are the major issues. But why don't we just go around the room, and again, we have Thursday's class to go over whatever we don't go over today. So maybe we'll go over nutrition and then do gun control, or maybe we do gun control then nutrition. Was everybody pretty much able to get through most of the material just to prep for class today? Okay, I don't see anybody saying no for the most part, so that's good. I just don't, it just becomes an exercise in futility if I'm the only person who's looked at the materials. But I'll still drag it out of you one way or another, so it's all good. Just you know what, everybody just raise their hand so I can see you on the participant list, and then I'll just call on people based on the raised hand. So just on the bottom where it says reactions, just click on raise hand. So I can look at and then I'll just call on people and take your hand down. I'm up to 4 people with raised hands. Got 3 more people to raise their hand. If you don't know how to raise your hand, wave wildly. Do you know how to raise your hand, everybody? Amy, Jenny, and Madeline don't have their hands raised. Do you know how to do it?
Yeah, I keep saying that my Wi-Fi thing's not working, and every time I try to click on the Zoom link, it's not letting me raise.
Okay, well, you know what? Then I'll just make it easy. You can answer the questions. A couple of topics that were of interest to you from Kaiser Health News, and then where you stand on your topic.
I mean, I found the California Health, it sent out this morning, and it was all about gun violence for the most part. I thought that was pretty interesting, but another one was crap, now I can't find it. But it was something about abortions that was also pretty.
It's been dominating Kaiser Health News. I mean, the shootings, especially since they had the 2 concurrent shootings, and that's why I wanted to bring up gun control, because there's so much discussion back and forth about do people think California has lax gun control or crazy gun control, meaning very, very intense? Or middle of the road. I'll give you an example. Massachusetts has crazy gun control. I mean, all sorts of requirements. New Hampshire has virtually none. So where do you think California falls in that, knowing whether it's a conservative or liberal state?
I feel like I want to say it's more lenient than Massachusetts, because that's where I'm from. So
it's almost as bad, if not worse, than Massachusetts. They have some of the strictest gun control, and they account for that gun control for the fact that they're the seventh, they have the seventh fewest gun deaths in the state, and they say it's because of their regulation. And you know, one of the problems here is that both the people had semi-automatic pistols that they used in the shootings. So people who are going to just cross over the state and go to Nevada and buy a gun can bring it right back. A lot of it's unenforceable. So it really speaks to whether, you know, whether state gun laws will ever be enough or whether we need federal gun laws. So it raises that whole issue as well. So yeah, very hot topics. And what did you say again your topic was?
I was thinking about doing PFAS, but I've narrowed it down to either in water or in nonstick cooking ware.
Okay, yeah, just choose something really super narrow. That'll be great, just to make it easy again for you. And you know, and intermittently I keep hearing about the nonstick cookware, so I'd be curious whether it's a real problem or not, and whether, again, I'd actually be curious if other countries regulate any of it, or whether it's viewed as because other countries, especially resource rich countries like Europe, probably have even more rigorous environmental and chemical protections than the United States. So I think it's a good topic. Just make it really narrow, because I think that the PFASs, as we discussed, are in everything. Okay, so that's great. Jack, can you just, because you weren't on the line when I asked people to raise hands, so you don't have your hands raised, so I'm just going to call on you, and then I'll just go through the list from there. What any topics of interest and or from Kaiser Health News? And then I know you've already talked about, but we haven't had a meeting about your topic, which is alcohol, screening for alcohol abuse, use disorder, and through using the EMT system. I think it's a very interesting idea, but have you done a Google search of it? Have you looked into it at all at this point?
I've looked into programs that are out there to see what's out there that they have, like, not necessarily a prevention, but I guess they do a little bit of prevention work, but it's all like resources that first responders have now.
Yeah, no, I'd be very interested, and you know, I'd be very interested in how you screen for it, because you know, somebody may have an episode of drunkenness and end up interfacing with EMTs, but that doesn't necessarily.
Most of the screening starts with like a department's policies, like the chiefs or captains like are forcing guys under them to like take classes and look into prevention, because it's such a big deal that people don't like ever talk about. They just deal with it on their own. So
yeah, no, I think it's if you can find a model program, that'd be a great thing to write a 10 or 15 page paper about, you know, model policies and procedures of departments, and how, you know, getting people to the resources is key, you know, getting people screened and then to the resources that are available. And there's a lot of freebies out there. And so, yeah, I think it's a great topic. Yeah. So schedule time with me, because we haven't chatted about it, and we'll just run with it. And any topics in Kaiser Health News that interested you?
I saw a headline about the pharmacists and their new rules with prescription, and that was interesting. I hadn't heard about anything like that before.
So one of the topics I think at some point we'll talk about during the semester are and I put materials in Moodle about advanced clinical providers. Everybody wants to be called a doctor, whether you're a physical therapist or a nurse practitioner or a nurse anesthetist. Pharmacists want to be called doctors. And there's moves and there's this whole discussion of scope creep. The AMA is dead set against it and says only doctors should do all the stuff, or everybody should be supervised by doctors, and then the rest of the world. And they've made some very inflammatory comments against nurse practitioners and other advanced clinical providers. So that'll be a great topic. And so one of the things that is being proposed is that pharmacists be allowed the ability to write prescriptions in, you know, a prescribed area that they have training in. And again, the AMA is fighting it tooth and nail. What's the middle ground? How do we handle it? So those are topics we will talk about, and I'll be interested to hear your feedback. So that's great. Amy, the two issues. That meaning your topic, where you stand with it, and then you meet for your paper, and then anything in Kaiser Health News.
For Kaiser, I thought it was interesting a lot of countries are still in danger of like not knowing how to handle another pandemic, which I kind of thought was interesting just from COVID. And then I feel like after COVID, a lot of countries were thinking, oh, we know how to better prepare for it because they hadn't really faced that before. So I kind of thought that was interesting. And my topic, I'm doing kind of like the baby formula. And
Yeah,
like
that's a great
prevention.
topic. I love that. And narrow it down as much as you can, like either federal solutions, private sector solutions, FDA solutions, state solutions, because states can potentially say, provide incentives for, critical food items that, are life-saving, and baby formula is pretty unique in that spectrum. But again, be very interested to hear it. And again, just keep it narrowly focused, like a proposed one and why it works, or what is good about the proposal and what's not good about the proposal, for further discussion. So that's great. Definitely like that. I'm sorry, what did you say on the Kaiser Health News side?
Just about how like countries aren't prepared for like another pandemic.
Yeah, no, it's interesting because we're going to spend one class or half a class on long COVID and the implications of that, and then another, lessons from COVID. So yeah, that'll definitely be a topic that we're going over. So terrific, that's great. And you can take down your hand now. Here, I can do it. You don't have to do it. That way I can keep track. Jenny.
From Kaiser, I thought that it was interesting that Biden is like shutting down like the pandemic emergency,
That was
and that
all
we're
over
like
the news
expecting
this
a
morning.
skyrocket with everything.
There was
I was like reading it and I was like, wow, like we're kind of getting to the end, but there's definitely going to be some spike in prices with everything. With like
well, and
people
a
still
lot of
being-
people will lose their insurance altogether. You couldn't shut people off from their insurance while COVID was considered. But May 1st is supposed to do it. And it was interesting that The Hill, which is a Washington online paper / journalism resource, said these are the 3 results of when the pandemic emergency is technically over. And most of it was not particularly draconian, but it's definitely going to change things. And all these pouring money into people's hands is going to change things. And then your topic for your paper.
So I'm doing malpractice, but I'm focusing more on like surgical safety and like specifically neurosurgery, and I still need to just find an age group of like what I want to do, and diving into more like finding like wrong surgical sites. Like if a patient did like a spinal surgery and they were doing it on L2 and they did it on like L4.
Right. And you educate the class as to what percentage of neurosurgical malpractice is wrong level or wrong site surgery?
Yeah, 1 in 10 people go into surgical claims specifically with neurosurgery. So that was like a big like shock to me. And that
it was a
people are
shock to me too. I never
having a
realized it was that
bunch of
high.
medical problems with that.
So yeah, a great topic for a paper, since it's a never event. Wrong level or wrong side of surgery is supposed to be a never event. I've seen it many times during my 30 years of clinical practice. So it'll be interesting to see what mechanisms there are to prevent that moving forward. So that's great. I'm going to lower your hand. Sydney.
So I read this article about how the FDA is like easing back on the restrictions for homophobic men for donating blood. And so now like, I don't know, I can't say the monogamous, is that right? Monogamous men can now, homosexuals can now donate blood.
So yeah, it was a hot topic. It was basically people in stable relationships and with a single partner who are test as showing no, either on medication, pre-exposure prophylaxis, or can now donate. The only problem I have with that is I wonder if they're getting informed consent from the people who are getting the blood, Because I'll be honest with you, if I would have the choice of either donating my own blood or selecting a blood donor who is neither, it doesn't inject intravenous drugs or doesn't have same-sex men on men sex, I would choose somebody who doesn't. So it's actually an interesting question whether patients should have a choice when they're getting blood to not choose even a remote risk. And, you know, remember we talked about informed consent briefly, risk, benefits, and alternatives. And if there is an alternative to have the safest type of donor as the person you're getting your blood from, I think that would be important. But yeah, it was all over the news this week in the past 3 or 4 days that they were changing the blood donation. And it certainly makes sense. I mean, it's extremely low risk. And then your paper?
So I looked into a ton of different articles on physician-assisted suicide and like what leads patients to like asking for that and stuff like that, because my original topic was like husbands and wives killing the other for like their benefit because they wanted to die. So then now I've kind of shifted more towards physician-assisted suicide. So
the Massachusetts Supreme Judicial Court just passed a decision saying there was no constitutional right to get help from a physician for for physician-assisted suicide. So now it's going to be up to the legislature if they pass something in that regard. It's not a whole lot different than when Roe was still in place. Physicians who are morally don't feel comfortable doing it, whether it be terminating a pregnancy or providing a prescription for drugs so somebody can make a decision on their own, are not required to do it, but they shouldn't prevent others who feel comfortable with that decision making from doing it. So I find it kind of paradoxical that people, are willing to go beyond and say, look, if you have an understanding with your patient, you think it's moral and ethical to do, and your patient wants that, why would other people stand in the way of that happening? You're, fulfilling the patient's wishes. So anyway, yeah, looking forward to it. It's a great topic. And you can look at, there's, I think, like, I want to say 12 or 13 states where it's legal. You might want to find the ones that do it the best. It's a fairly complicated, but if you narrow it down and choose like 2 extremes of states and sort of compare them, or countries too, because there's some countries that it's completely allowed and others that it's not. There's a wide spectrum. So yeah, so as you do your research, I'll be interested to hear what you find and what you find interesting. So great, I appreciate that.
Nick.
Yeah.
Nick. I kind of want to hear a little more about it, but like to your point about the informed consent for people who have possibly need like blood transfusion, people who are getting donated blood possibly, just like, I don't know, I feel like how can you possibly, like, I know in the past, like especially in the 80s with the whole with the epidemic of HIV, AIDS, but like screening for infections in the blood was more lax. But compared to now, I feel like I can't expect that happening without like there being some type of discriminatory practices involved. Like how can you possibly, like, blood, like they're screening for the blood infections and stuff like that, but how, like, at what point can you like ask, like, oh, at what point can you ask the patient, like, oh, I want this person who was a virgin, like stuff like that, you know what I'm saying? Like, I'm kind of curious about, like, to hear a little more about that.
Yeah, sure. So, I mean, to me, it's pretty straightforward. I mean, when you're going in for surgery and you might need blood, I think it's completely reasonable to say, do you want to donate your own blood? And there was a whole movement for a long time of donating your own blood. So a month or 2 before surgery, you donate your own blood in case it's needed. And likewise to say, look, I'm going to ask friends and relatives to donate blood. To me, it's discriminatory against the person who wants to choose the safest thing that they think is right for them, versus saying, I'm not saying that anybody, if the FDA says that this is a reasonable, or the American Red Cross says this is a reasonable and safe practice, then people can donate blood. I guess the question is, do we undermine people's autonomy to either give their own blood or choose choose who they, including friends and relatives, give blood if they need it. And frankly, to be honest with you, it's probably an even better idea to allow people to decide, because they'll donate their own blood, which will make it available for other people to use, because they're overwhelmingly not going to need it. And if they have friends and relatives donate blood, that as well is overwhelmingly not going to be used. It would dramatically increase the amount of blood available to people who might need it.
Is that not an option? Like,
I've never heard of it. Have you heard of it? I've never heard of
I've
it.
never heard of it. No.
Yeah, so nobody's doing it. I've been in healthcare for 30 years, and I've had 2 major surgeries in the past 15 years. So none of that was ever discussed with me. And I'm sure I was cross-matched in case there was a bleeding complication during my surgery. And there, thank goodness there never was. But I mean, that's a perfect example whether if that had been presented to me, I probably would have given some blood, and I might have asked, whatever, friends, relatives to give blood. And I think it's a good thing. It's a great incentive for people to give blood who otherwise might not. I mean, you might not be a routine blood donor. I have terrible veins, so I don't routinely give blood, but it might be a great incentive to just increase the amount of blood that's available for everybody if you put that into place. But those are the kinds of things that I like sort of thinking about in terms of how we make it better for everybody, and at the same time maintain people's ability to make their own decisions. Does that make sense? Or
Yeah.
cool. Monica, did you already speak? I think.
No.
Okay, go for it.
From Kaiser Health News. I also looked at this abortion thing. It was all over Kaiser today. The Virginia Democrats, they blocked the bill that limits abortion. That was like 15 weeks, I think. They proposed a bill. And I think that was like a step forward in a Republican state, because Democrats blocked the bill.
Yeah, I'll tell you, this is a nightmare. I mean, people are just going to be crossing borders left and right. I mean, we've got all sorts of, and one person's doing a paper on it, but we've got all sorts of, like the Texas law, you don't even know you're pregnant at 6 weeks. So, I mean, it essentially just basically bars any kind of abortion. And then there are states that say a fertilized egg is a human being and deserving of state protection. So again, just completely eliminates the ability to terminate a pregnancy. And again, the ramifications of that for people like who have ectopic pregnancies. So ectopic pregnancies are pregnancies that implant outside of the uterus, and they're lethal. Dozens of people, young women, die every year due to ruptured ectopic pregnancies, and they exsanguinate into the abdomen. So doctors in training, especially if a young woman of childbearing age comes in with fainting, one of the first things they think about is this a ruptured ectopic? Is this fainting from hemorrhage rather than vasovagal? So, the first thing they do is check hematocrits and do all the stuff, postural blood signs, and make sure their blood pressure is good. Because if it's vasovagal, they're hypotensive but bradycardic. If it's hemorrhage, they're tachycardic and hypotensive, which is a disaster. So yeah, no, it's a huge issue.
Yeah. So for my topic, I am comparing the financial spending between America and Switzerland in healthcare, and proposing a recommendation to America.
Great.
Basically,
Yeah. And narrowing it down to two countries makes your job infinitely easier. You don't have to be thinking about what they do in Israel or Germany or any other resource-rich country, and just say, what's bad about the American system. You don't have to spend much time on that. It's just, we have a whole class of why 2 full lectures on why the American healthcare system is broken. But what would be the advantages and disadvantages of the Swiss means of healthcare finance. So and part of the spending is what they determine are essential health benefits, which we've never been comfortable doing in the United States. So we don't pay for heart transplants for people over the age of 90. That we do a lot of crazy things and pay for a lot of things in the United States that would never be considered in other countries. So it's definitely a great topic. And then how you actually propose the financing for it. and whether we can afford it. We certainly can't afford it at the current pricing, but if everybody's part of the system, if all the docs are employed and all the hospitals are nationalized, it'll turn the world upside down, but it'll be infinitely cheaper than it is now. So yeah, great topic. Oh, one thing I wanted to mention, we've got 4 more people to go through. But if I find something, the default will be if I see something in either the medical literature or public health literature that's on your topic, I'm going to send that to you, unless you specifically don't want me to send it to you. Is there anybody who doesn't want me to send stuff to you on your topic if, as I'm perusing the literature, I see something that's germane to what you're writing about? I just don't want you thinking that, like I'm preferentially helping one person over another, or you'd just rather do it on your own and not be biased by what I find. And the stuff I find will be all over the place. It's not my agenda. If I find it and it's germane to your topic, I'll send it to you. So does that make sense for most people? Okay, cool, great. And again, if you change your mind and you don't want me to send, and there's not that much stuff out there. You might hear from me once a month or something if you have a topic that's hot and there's something written about it. But I've sent something out to a couple of people already, and both of them appreciated it. Kelsey.
Hello.
Greetings.
What would you like me to start with?
Either one. There's a 50-50 shot on whether it's a Kaiser Health News topic or your paper, and both are good.
Okay, so for my paper topic, I'm doing like trying to decrease the number of deaths in children. I think it was like 1 to 19, and I was like planning on narrowing it down by like motor vehicle injuries. That's like one of the #1 causes of death in children.
So it used to be, it's a great topic, and I would definitely choose a very specific cause of death. So it used to be trauma, and motor vehicle accidents was the #1. Well, trauma generally was the #1. Hang on just a second here. Trauma was the #1 cause of death in children. What is the #1 cause of death in children now? It's come up recently.
Motor vehicle injuries.
So that's the traditional one. It's actually been supplanted since then. In the past,
That's what we were just.
That's
what they had just told us in like classes. Hold on.
Yeah, so they're behind the times. I can send you 5 articles that came out in the past 3 months that say that gun violence has supplanted trauma as the leading cause of death in children. So why do you think that's the case? Because when I read that, I'm like, that's insane. There's no way that's true. And then I saw a drill down analysis of why. Somebody can Google it. Well, I don't want to Google it because I want to sort of keep going on the class, but somebody can Google #1 cause of death in kids, and you'll find and just say and put in
One's COVID right now is a leading cause of death for children in the US.
I read that was on Kaiser Health News, I think today. Yeah, but
it's on like CNN too right now.
Yeah,
that got posted yesterday there.
Yeah, no, that's when I read it, I think yesterday as well. I was surprised to read that because it's so not lethal to kids, but there's just so many people getting it, and the numbers are all over the place. Part of that story actually indicated that 98% of the kids show antibodies to COVID, under the age of 19, which I thought was like staggering, because I've read different sources, and I think they're wrong, that like somewhere between 100 to 150 million of the 330 million people in the United States have had COVID or been vaccinated. And I think the number's got to be close to like 275 to 300 million people, because everybody's been exposed to it. It's highly transmissible. And I think we've gotten way over 100 million people, or 150, who've just been vaccinated alone. And a huge portion of those who have not been vaccinated have gotten it at least once or twice. So, but I'll send you the stuff because I've got it, that says that guns are the cause of it. Actually, well, I'll do it after class, but
it's like they just like posted that firearms has surpassed motor vehicle injuries, but that whole thing is like 0 to 19 includes the perinatal conditions, unintentional injuries, congenital malformations, deformations, assault, suicide, malignant neoplasms, disease of the heart, and the flu. So a lot of them are like accidental deaths, Like,
I'd have to look at the definitions. All I know is I remember seeing in at least 5 different sources that guns.
Yeah.
And of course, I'll have to tell you, remember I told you about the sniff test, something didn't make any sense. So it didn't make any sense to me that guns were the leading cause of death in kids. So why do you think that if you do the breakdown on it, how did they come to that determination? Any thoughts on it, Kelsey?
well, so thinking about like what like has been in the news and like the statistics of it and like all the things that like come to mind, school shootings have increased significantly.
That's
And
1%, less than 1% of gun deaths. But you're
there's
right.
also parents who don't store their weapons properly,
So,
kids who are suicidal,
and
and
those
have
are
access to a weapon.
right. So those are all absolutely correct. And so suicide in kids is much less frequent than in adults, and they certainly don't use firearms that much. So that's why that didn't make any sense to me. And then lastly, unsecured weapons. I mean, how many homes have unsecured weapons where a child has access to it and has access to the bullets and figures out how to shoot either themselves or another child. So it turns out when I did the drill down on the data, it turns out that the vast majority of gun deaths are gang related. They're males, typically minorities, and in the 15 to 19 range. So that's why gun violence and gun deaths have increased over motor vehicle accidents, if you're to believe in it. And I'm glad you question everything you read, because I do. I mean, because sometimes it just doesn't make any sense, and you want to know if the data is completely skewed or they're using definitions that nobody else uses so they can make for a good headline and make it clickbait. So yeah, no, I think it's a great topic, but yeah, I requested for you to schedule some time. But if you narrow it down on your own, that's fine by me too. Just narrow it down to whatever, but make it really narrow, just so you can make it easier. I mean, because what's going to happen is, especially if you do like motor vehicle accidents, what do people think, just as a gut reaction? And I've done a little bit of reading on this. Why motor vehicle deaths have gone down. And it's across the board. It's not only kids, it's adults as well.
Isn't it like the newest development of like seatbelts, like the current models? Also, cars are a lot safer, like they're built to withstand more crashes.
Yeah, so the bottom line is cars have changed so much in the past 30 years. We have crumple zones, we have multiple airbags, all of which have saved tens of thousands of lives. So that's really the name of the game. And you might say, well, that's an important public health intervention, and it is. Making everything safer, from your cars to your food to everything, things that we interact with on a daily basis, is always a good idea. So that's important. And then I'm sorry, what was the any Kaiser Health News thing that you thought was interesting again?
I found like a couple of like articles about like drugs. So like cystic fibrosis, like they're making a new drug cocktail for it due to like the shortage of antibiotics. And then like also there's an Alzheimer drug that Kava Sciences has been like testing, and they like just found that it's just as effective as a placebo. So like literally receiving nothing.
Yeah,
And then
yeah, you're absolutely right. Unfortunately, that's been the case for almost every dementia drug that they've researched. That placebo does just as much. And even the ones that were recently approved were highly controversial and had really horrible side effects like brain hemorrhage, and they had to be injected and they were very expensive. So I find it unfortunate that, because it's such a devastating illness, and it's so sad for people who have, who are either have a relative or a family member or friend who has it, that it really pulls on people who are desperate for solutions and will try almost anything, even if that anything puts their relative at risk. And nothing reverses the dementia. Most of these drugs just barely slow the progression, and even that's highly arguable. So it's really a sad statement as to what motivates us to do stuff, in terms of approving drugs in an expedited fashion, and the right to try treatments, experimental treatments. I mean, again, it's preying on the most vulnerable. Kylie.
for Kaiser, I read about CRISPR, the gene editing tool, turning 10. And like that was something I was interested in high school. So I thought that was like cool.
It's certainly going to revolutionize the treatment of every disease known to man. The problem is it's just not ready for prime time. We just have no longitudinal studies or clear safety or efficacy or what are the known side effects when you start messing up with the genome. There's going to be a ton of research on it, and I guarantee you there's going to be a ton of unforeseen side effects. But you know, this is the progress of science. You know, one step forward, two steps back.
I'm pretty sure like someone was arrested from that company for like this. They modified like these babies' genes, and then I got into this whole like debate. It was a crazy thing. I remember reading about it a while ago.
I know there was a guy in China who did it, who was
Yeah.
experimenting on kids, and he was sanctioned and got in big trouble. I think the Chinese government put him in jail. I mean, it was it's considered unethical to do this kind of stuff on humans until we've established that it's safe and that it works. You know, if it's a single gene or transposition of a single you know, base pair, maybe it works, maybe something super simple like hemophilia, but many of them are polygenic, and many of them have you know, microbiome and environome impacts, and we just don't know what any of those things do. So you know, the whole genetic and CRISPR technology is fantastic, it's exciting, but it's also just so not ready for prime time. So not ready for prime time. And just
like scary.
Oh yeah, no, and then I don't get into the eugenics of it. I mean, people choosing to have either male children or female children, or children who, you know, are going to be exceptionally gifted, so for athletics or something. I mean, there's something to be said for you know, just natural the natural creation of children, and you know, taking the pluses and the minuses rather than sort of creating designer children. That's also just a fascinating topic about what's ethical and reasonable to do in that whole sphere. We're definitely going to be into some serious, plenty of conferences going over that topic. So yeah, good stuff. And did you covered both your topic and
my paper topic we went over today, but it's like I'm looking more into the funding for children's healthcare.
Okay, yeah. So just so the rest of the class knows, and then you can update us on, you know, if they're particular, if either when you do a global comparison of what other countries do, or if you want to choose a particular state program. But we talked about a paper from Health Affairs, which is probably the premier public health journal, talking about you know, permanent funding for CHIP, Children's Health Insurance Program.
Yeah,
that's cool. Great. Keisha.
Yep. In Kaiser Health news, one of the things I really found interesting was that the federal government is stopping the extra payments that were going to families that are enrolled in SNAP. It was $95 a month, which doesn't seem, or it looks like it was an average of that, which doesn't seem like a lot, but when you multiply that by 12 months, it's $1,140. And with food prices having increased so much, and we're already, you know, people aren't eating the healthiest, especially when there's a limited income. It seems like a crazy amount to cut from people. But
so, yeah, no, I think it's an interesting dilemma. And there was literally in the news today, I sent it out to my mom and a few other friends. What percentage of the population lives paycheck to paycheck? 20, here, we'll do the hand raising thing. 20%, 30%, 40%, 50%, 60%, 70%, 80%. So it's again in the news today, you can Google it, 65%, including 9 million people who live paycheck to paycheck, and they make over $100,000 a year. So it's not only poverty, it's people who are spending way beyond their means. So it's really a huge problem. So sometimes that $95 is the difference between eating and not eating. And of course, we don't, as a society, spend a lot of time teaching people about doing, you know, budgeting their money well, and making sure they're not spending more than they make. I mean, I just hear about way too many people who are, spending hundreds of dollars to go to sporting events and can't pay for their car insurance or their oil heat in the winter. So we definitely have a completely capitalistic and consumer driven economy, and where we're encouraged to spend money on everything, whether we have the money or not. And credit card debt is at record levels. Talk about spending money you don't have. So
Well,
scary.
that book that I emailed you about earlier, there were a lot of different like points that she made in that. And one of the points that she had made was that we already have a system set up so that payments are made automatically to people who are eligible. So why is it one lump sum payment at the beginning of every month? Another point that she made was that a lot of grocery stores, unfortunately, have a practice of increasing prices at the beginning of the month, knowing that people with benefits are going to be coming shopping because they're out of food.
So it's a really interesting problem. And how are you prevented from buying Cheetos and pork rinds and potato chips out of your food benefits, or you're just
No.
like to be able to buy that as healthy fruits and vegetables? And that's another problem with the program. I mean, there's, other than alcohol and tobacco, I think you're allowed to buy almost anything you want.
You're not allowed to buy anything that's like anything that's warm or anything that's ready to eat, or like single serve things. I mean, you can buy like single serve yogurts or stuff like that, but like I remember learning that like you couldn't, like if you go to the grocery store to buy food, you couldn't buy like a
A
heated
hot dog.
sandwich.
Yeah.
Yeah.
Because a lot of stores sell pre-prepared food. I mean, that certainly makes sense. You can feed a family a whole lot better if you're buying, staples that you can stretch out your budget, as opposed to, junk food or processed food or ultra processed foods, which are neither healthy nor nutritious. So yeah, just a quick anecdote. I was in BJ's and the person in front of me was buying frozen lobster tails and bacon wrapped scallops. I'm thinking, I got to get invited to that household. And then she pulled out her card and I'm like, wow. And then she didn't even have enough money on the card. So they made her they said, well, you don't have enough money on the card to buy all these things. And they just took it all back and put it back in the freezers and stuff. But I actually asked them, I said, there's no restriction. With your card, you're $95 a month. You could buy frozen lobster tails and feed yourself for one meal. And what the cashier said, we see it all day long. I mean, it's an anecdote, but it was just shocking to me. There were no prescriptions, or no, at least even guidance, help people to choose healthy foods that they'll be able to, that are nutritious and will last the month. And
I just want to add a little tidbit about it. I did my internship at Waypoint in Concord. I'm not sure if you're familiar with them, but it's pretty much like a low income family program to help them with like how to get back on their feet again. And I experienced like a lot of families who are on SNAP and WIC, and actually WIC is more strict with all the food requirements than with the food stamp program. And like there's actually like a list of guidelines that like you have to get, or they'll cut you off from their program, which is like, these families need to eat. And if they have to stay within a budget, like if the budget's $95 a month, like who can feed a family of like 4 or 5 with a $95 budget a month?
agree,
Like that's just insane.
Well, WIC is set up differently though, because for WIC, they it's like certain things that you have to get, but it's not based on like a budgeted amount. It's just like, for example, Vermont uses a card for WIC. And so you have to get, say, milk, and say you need to get half gallons of milk. It's a specific size requirement and specific brands. That way they're not paying, exorbitant amounts, but people are getting what they need.
But I also like what WIC does, that on their website, they have recipes that like goes with the food requirements, which I think SNAP should look into more, but I'm not even 100% sure if SNAP does that or not. I was doing for one of my projects like a newsletter, and they were like, oh, add like different like recipes for families to do. And I was like, in my head, I was like, okay, if half these families are on food stamps or WIC, like how am I gonna like figure this out? And I was doing more research about it, and I saw like WIC had this whole thing about like cooking with your kids and like doing like other like big recipe stuff that could help with like the whole like budgeting thing, which I thought was super interesting. But it's a bit, I didn't even know how big like the whole like national food problem was until I just like finished my internship. It's just so bizarre to me that it's like a big problem.
Yeah, no, it's a fascinating topic that I know very little about, but clearly it's infinitely cheaper to cook from scratch and create meals than it is buying all pre-prepared meals or frozen meals, which are infinitely more both expensive and processed, so less healthy as well. So yeah, it's a really interesting dilemma. And then we're talking about nutrition today, so we can talk about even the YouTube that we saw about the Pennsylvania Health Bank and the Geisinger Health Program that has started their pharmacy, FARMACY. So interesting stuff. Amisa.
My paper topic is occupational health and inmates. I haven't really, I mean, I'm not struggling with the lit review or lit search. I just like haven't gotten too extensive deep into it. That's about it. And for Kaiser, I had the same article as Sid, but I kind of just same points and everything, like just same thing, but I kind of was just thinking about it, and I don't want it to make it sound like I'm like arguing with you or like opposing anything that you're saying, but like just thinking about it more, I don't know, like the whole, like patients, yes, I agree patients should have autonomy, but I also believe that, in my opinion, I feel good, I feel decent that patients can't pick who their blood donors are, only because I feel like it just contributes to the racism and the sexism and the homophobia that already exists in the United States. Like, you're telling me, like, it's just, I'm sorry, I'm kind of getting a little worked up, but I don't know, I just feel like the miseducation, the stigma that already exists in the United States health system is just going to translate over into that sector of health. And people, there was a whole syphilis, like bad blood, there's just a lot of there's a lot of things that could sway people's decision on who's donating blood and kind of distract them from the ultimate goal of possibly saving their lives, you know what I mean? So I'm kind of happy about that. Like, I think it's for the greater good, in my opinion.
Yeah, no, there's just tremendous, and feel free to disagree with me on every topic known to man. There's reasonable minds disagree on tons of stuff that's out there. And everything is, what are the benefits of doing it this way? And there's always a balance between public safety and trying to minimize inherent bias and discrimination, which is just rampant, and disparities in healthcare. But again, you're always weighing sort of societal good against individual autonomy, and that's a balance you're going to find in every topic that we. Do we tell people what they have to eat, or do we, in a more prescriptive way, say, we'd like you to purchase these following food groups because it's going to enhance your health and make you better. And some people say, I don't need Big Brother telling me what to eat. If I want to eat Cheetos, I'll eat Cheetos all day. I don't think it's particularly wise. And then a lot of times people say, well, you will just use education as a means to change human behavior. Unfortunately, education just doesn't work that frequently. Oftentimes it's a very weak, either both motivator and incentive and means to change human behavior. More hardwired and more sort of systems changes are necessary to change human behavior, which again is the goal of tons of our public health interventions. So that's.
And I'm surprised that I don't hear more about this discussion in health. Like, this is my first time ever like contribute or thinking about both sides of the donor of blood donations. And like, I mean, I've never really, I feel like I haven't heard much about it, and it's almost like it's almost like a right and left kind of debate too. Like, I don't know.
Well, so for the longest time, it was just unsafe because, you know, they didn't know whether they were circulating, you know, any infectious possibilities with certain conditions. So, you know, for there are many types of hepatitis that for years we couldn't test for. Now we can test for the vast majority of them. So we can screen blood in that regard. But now we have established highly effective treatments. And for people who have are monogamous and have only one partner, so that there's no risk of, early infection and undetectable levels. I mean, the problem is a lot of this is just, how many people, say I'm monogamous with my partner, but their partner's not monogamous with them and they're unaware of it. I mean, cheating is rampant, both heterosexual, whether you're heterosexual or in any kind of relationship for that matter. So, you end up relying on a lot of information. And so, clearly, again, donating blood, if you say, hey, I'm married and, monogamous, but between polyamory and all these other choices that are out there, there's huge spikes of sexually transmitted diseases in populations where there's polyamory or practicing not safe sex. So again, whether it's homosexual, heterosexual, or other. So I think these are all the facts that you need to know. But the reason that you can now do it is because you can screen for it and people can attest to the fact that they're healthy and they have no detectable levels, which I think is great. It just increases our blood donor pool. So and again, I think it's good. I think overall allowing people to choose, as I mentioned earlier, I think would enhance the amount of blood that was available. But again, if they could actually study it and figure out if it would be a 10 or 15 or 20% increase in the in blood donation if we encourage people to donate their own, which will overwhelmingly be used by others and friends or relatives donating. So anyway, it's a really interesting topic. So I agree with you. And then I'm sorry, your paper was again?
Occupational health for
Yeah,
inmates.
so we definitely need to talk. That is just, there's like entire courses on subdivisions of occupational health. So is there a particular industry or particular
No.
yeah, so you really need to, so yeah, let's just, Google it and then schedule some time with me, 10 minutes so we can just really, really narrow it down, because you're just going to be overwhelmed. I mean, there'll be 10,000 references and hundreds of thousands of pages of material. So choose a very specific, like occupational health in this industry doing that. Or just a million different ways to narrow it down by industry, by work type. So that would all be, I mean, somebody's doing the interesting topic of, I think, worker safety in prison workers. And I think that's a really interesting and a narrow topic. So I think that's really interesting and much more discreet and you can explore sort of the ramifications of it. So that's good stuff. Why don't we take a 5-minute break and we'll reconvene at 1 o'clock. Perfect. So bunch of materials on nutrition and then a bunch of stuff on gun control, since it was interesting. Should we start with the nutrition or gun control? Give me a raise of the hand for nutrition. Give me a raise of the hand for gun control. So we're going to do gun control then on Thursday and start with the nutrition. So any thoughts on the Geisinger pharmacy program? Good idea, bad idea? Should they be spending millions of dollars on it? Should they be spending a very limited budget on it? What are the incentives of the current healthcare delivery system in terms of whether you think it'll be adopted at other places?
I think it's a good idea. I like the program mostly because I think I feel like a lot of a lot of behavioral lifestyle changes are like, they don't happen because people don't have feasible alternatives. And so the program giving them these meals regularly, 10 meals a week, I think. 10 meals a week. I think that's helpful because, I mean, it gives people who can't eat nutritiously the tools to do so.
So I think that's a great point, and I couldn't agree with you more. Do you see like programs like this going to be opened up and tens of millions, if not hundreds of millions of dollars be spent on them moving forward by other healthcare delivery systems? Geisinger is very progressive, by the way. What's the incentive? Let's just talk, it's always comes down, I hate to be so cynical, but it always comes down to follow the money. So what's the financial incentive? So I can't tell you during the course of interacting with people, people saying, yeah, but it'll keep people healthier and it'll keep people safer and we'll spend less money on healthcare.
So
Are those
I think
cogent arguments?
So I think that, if this is a hospital sponsoring this, right, from what I
Yeah.
could tell. Okay,
I think
so,
they're actually working with the Pennsylvania Food Bank for a lot of it as well.
yeah, this seems like, so, I think there's a couple different ways you can follow the money here. I mean, we all know that, like, I'm assuming that people know that food banks have donors for a certain extent, either corporate or private. So I'm sure that some of the money is coming from the food bank donors or donors to the individual program. But then if it's sponsored by a hospital too, theoretically, if you're successful at keeping people's, managed conditions like diabetes and heart disease to a lower extent of those happening, then they're saving money by not footing the bill.
Well, who's saving the money? Let's follow the money. Who's saving the money?
Well, if there's uninsured or underinsured patients, the hospital could be footing the bill for that, so they could be saving money.
Right.
The health insurance plans that the people are covered under, if they're covered under private insurance, could be saving money, so maybe they could be sponsoring part of it.
Right. So, I mean, there's the issue. The issue is the only place it's saving the hospital money is for your uninsured population, which is maybe 10-12% of your business, maybe 15 if you're in a particularly bad area. The insurance companies, a $900 billion industry, are saving money. Do you think they're handing that back out to society or to their subscribers? No, they're not. They're just making a ton more money. So there's really zero incentive to do this, because what was one of the first questions we asked in the first 2 weeks? Are we a prevention and health and wellness model or a sick care model? When do you get paid? Do you get paid for people who are healthy, or do you get paid for people who get sick and go to the hospital?
People who are sick.
So if I presented this great program for healthy eating and diet control and good nutrition, and have heart healthy diet that would keep your sodium down and decrease your numbers of readmissions and admissions for congestive heart failure down 50%, do you think hospitals would embrace that? They just lost 50% of the revenue they get from every congestive heart failure admission. The same is true for, the mold mitigation that we talked about with asthma and the environment, going out and making healthier living environment for childhood asthma. They just lost all the revenue from the ICU visits from all these kids. So it's just completely perverse that we have a sick care model that provides, doesn't provide an incentive to keep people healthy. There's strong incentives to have people get sick, because that's how they make money. More surgery, more admissions, more ICU, more lab tests, more CAT scans. I mean, the list just goes on and on. I mean, is there any incentive if you opened, low-cost charitable urgent care centers all around your hospital, if it would keep people healthier, get them seen sooner, but it would decrease your ER visits 30%? again, nobody's interested in it. And I have personal examples at a hospital I worked on where they literally shut down a really proactive and beneficial population health management and primary care because they realized, and our hospitals, do hospitals make a lot of money in ERs or don't make much money in ERs? Make a ton of money in ERs because, as we talked about earlier in class, somewhere between $1,200 to $2,000 per visit, it's really easy to make a lot of money. And again, if only 10 or 12% of your people are uninsured, you're still, you know, you want the wait in the ER to be, 15 hours all day and all night, so that, you're just constantly feeding the beast. So yeah, it's very paradoxical. So it's a great program. It's a great idea. It's the right thing to do. Unfortunately, the way our healthcare delivery works, oftentimes the right thing to do is not incentivized properly. What did you like about the YouTube on the Central Pennsylvania Food Bank? Anybody who's not spoken? Raise your hand if you watched it, because if you haven't watched it, obviously I'm not expecting you. So anybody who watched it, and Amisa, you already spoke up, so thank you, and we'll circle back to you for the next topic. But I just want to give everybody a chance to earn their 15% in terms of participating. So, good program, bad program. What did you like about it? What didn't you like about it?
I think it was a good program from what I watched.
Yeah, I thought it was a great program. I mean, they not only,
I think we need more.
yeah, I'd love to see more of them. I mean, the thing that was great about it too was not only did they teach recipes, but they did a ton of education about what to eat and how to keep yourself healthy and what's a good diet, and goes along with Poland's thinking of if it comes from a plant, eat it. If it's made in a plant, don't, which I thought was just a great quote. So, sort of not minimal processed foods and primarily, fruits and vegetables. And what kind of diets are the healthiest diets?
Well, like food, like plant-based diets, but the video I watched in another class, so I've already seen it, but I thought I watched it in my human biology class, which I found like very interesting. But just like the whole like process of like being able to educate people on like what's the right food to eat and not right food to eat, and just like teaching them is like so important, because I feel like no matter like what like status you're in wise of money, like you can always learn how to like cook like food properly and what like right nutrition you can get for your family, because it's just gonna like affect your health in the long run.
Yeah, no, I mean, the statement "you are what you eat" has never been more true. It is absolutely crucial, but it's not only education. Remember, I said education is not a great means for changing human behavior, and it's not. It's a terrible means for changing human behavior. But the kinds of things that do change human behavior is you tell people how to organize their refrigerator so all the foods that are healthy are on the highest shelf and easily reached. That's like a mechanical, physical way to intervene in behavior. I could walk over and show it to you, but the camera's attached to my computer. I literally put obesity on my refrigerator, and so that I could just be constantly reminded that, eat the healthy food that's in the fridge. And then what I've done is I just don't buy bad foods anymore. I mean, before it was like, oh, well, I'll buy some pretzels, and oh, I'll buy some of this and some of that. And you know what? You can't eat bad foods if they're nowhere in the house to be found. So try to stick to, fruits, vegetables, and, lean beef. Any diets that people think are particularly healthy? Have people heard of blue zones? What are the typical diets, other than obviously plant-based is very healthy, not processed? Any specific diet that comes to mind that has been shown to be quite healthy and salubrious? I think wasn't there an article that I gave you guys? Hang on. Yeah, I think there's a recent nutrition article on, here we go. But from the Nurses Health Study, which is a phenomenal resource. It's like 38 years old and has studied like 50,000 nurses over 4 decades. Anything mentioned in there about which diets were healthy Did anybody read that? It's only like 12 pages, but the abstract's just 1 page, and you can pull it up if you're curious. Were there any specific diets mentioned in that? Anybody remember Atkins? Anybody remember Mediterranean diet? Anybody remember? Yeah, so they talk about the Mediterranean diet, which has been pretty, and they actually speak specifically about the alternate Mediterranean diet. And a lot of it is just variations on a theme. Atkins to me is a great way to lose weight, but it's not the most healthy of diets because it says you can eat as much protein and fat as you want. You just can't eat carbs. So that's not particularly sustainable or healthy diet. Even though you may be successful losing weight, what's going to be the long-term outcome of the losing of weight? What happens a year or two later after you're done with your Atkins diet and you lose your 30 pounds?
You just gain it all back.
Yeah, most of these diets are just yo-yo diets. You just go up and down and up and down. And I know I've been there, I do that. And, so I completely, you have to change your eating habits. Diets per se are not, changing your diet, changing your eating habits is great. A diet per se. Do you know why there's like 1,000 diets out there and new ones are coming out all the time? Why do you think there are 1,000 diets out there?
To make money.
Yeah, it's certainly to make money, that's for sure. How
It's
about
like everyone's different.
so it's to me it's almost clickbait, but the reality is there's 1,000 diets out there because none of them work. So they're always trying to come up with something new and different. I've actually written about this on my blog, and they always come up with different recommendations for pediatric and eating meals together. And there's a lot of different information about it out there, but it's a really complex problem. So I'm just going to go quickly to the questions you were asked. I think one of the questions that I asked you is, what's a bigger problem? Malnutrition, because we always talk about diet, especially worldwide, and there are always pictures of people, the young kids who are just profoundly malnourished and bloated belly and have kwashiorkor and just awful situation. Is that a bigger problem in terms of deaths, or is there another bigger problem than that when it comes to diet? So the question on your for this week is, I'm waiting for it to open in Microsoft. Here we go. So the first question is, how important is nutrition in maintaining good health? Oh, so here's the second question that you've got, which is number 4. Is the first 2 are Kaiser topics, and update me in your paper. So the fourth question is malnutrition or adiposity a bigger health problem in the USA or globally?
I would consider it as like a global problem because if you're looking at like third world countries, they don't get like the food supplies like we do. So they have to like eat pretty much what's like, I don't want to say like given to them, but like food that is easy, like accessible to them so they can still have like a full meal. And they're not really like thinking as like it like not being like healthy, but they're just getting that what is accessible for them, in especially in the third world countries where they're really struggling with malnutrition.
So it's a great way to spin it and answer my question correctly, because the truth of it is, if you go country by country, I'm sure there are profoundly resource poor countries where malnutrition is a much bigger problem than adiposity. But if you take the United States and ask the question, what's a bigger problem, malnutrition, which there is malnutrition in the United States, or adiposity, there's a very clear answer. And if you take the world as a whole, there's a very clear answer. And what's the answer?
Malnutrition is a global health issue, and adiposity is the United States.
And you know what? That's exactly what I would have concluded. And it's wrong. It's actually adiposity for both, if you can believe it. There are far more people that die and suffer from adiposity if you take the entire world, the entire 7 billion people we have in the world. And what are the adverse effects, health effects of adiposity? Can we go through like organ systems of what it affects? Does it cause cancer? Anybody? How many cancers are, how many cancers, I'll give you a choice, multiple choice, you get to raise your hand. How many cancers is adiposity a risk for, an increased risk for the cancer? So 1, 3, 5, 7, 12. It's like 14 to 16 different cancers. It's considered one of the one of the greatest reversible causes that cause cancer is adiposity. And I didn't know this except in the past 10 years as the research has evolved. So it's a gigantic cause of cancer. How about orthopedic problems? Is that a problem? Huge. Knees, hips, absolutely, wear and tear. So that's, what about pulmonary? Yeah, if you start shaking your head every time I ask a question, you're on the right track. How about cardiac? How about hypertension? So what's one of the biggest morbidities associated and one of the leading causes of a disease that we're all very familiar with, that's associated with adiposity?
Is it diabetes?
Oh my God, it is by far the leading cause of adult onset diabetes. Home run. And what does diabetes do? Kills your kidneys, kills your eyes, kills your cardiovascular system, premature stroke, premature heart attacks. It is a complete disaster. How much of diabetes could be adult onset diabetes could be eliminated? Not juvenile. How much of diabetes can be eliminated if we could get people all down to a normal BMI? And we can talk about BMI as well, just because it's a somewhat controversial topic. What percentage? I'll give you multiple choice again. So we'll just go by 10%. And and the question is going to be, how much would you eliminate if you eliminated adiposity? So 10%, 20%, 30%, 40%, 50%, 60%. 70%. Okay, you all get A pluses. Yeah, it's a huge amount. It's somewhere between 60 and 80% could be controlled. And some people say you can completely cure with very aggressive dietary restrictions. You can completely cure 90% of, I think that's a high number of adult onset diabetes. While we're talking about all this stuff, I give you numbers and I'll give you percentages, and they're averages because, you can find something to show anything, like, that Biden didn't win the election, and find, 100 experts who say, yeah, that's the right answer. But, somewhere between, biased research and research that's not statistically significant and is sort of a consensus view of where we stand. So, I'm not going to argue whether you said it was 40% versus 60%. If you find something that's totally contradictory, please let me know. I mean, again, we educate ourselves in this entire process, but you may hear different data, including, we even had a discussion about gun, what is the leading cause of death in kids and stuff. And that's a moving target as well as definitional. So, please, if there's anything you read that contradicts something I say in class, please let me know. We can talk about it in class and really do a couple of drill downs on the data to see if the data is valid. I mean, there's so many studies out there that say this is a randomized double-blind controlled study of 40 patients to see if this intervention works. What do people think sort of about that concept of a randomized double-blind controlled study for 40 patients to see if this drug works or if placebo's better? Because you can put on your public health hat.
Can you repeat the question, please?
Sure. If I told you there's a new drug out, they did a randomized double-blind controlled study with 40 patients, and this drug cures diabetes. You just have to take one pill and it cures diabetes. And it's statistically significant. P of greater than 0.05.
First of all, I think 40 sample size is very small.
Yeah, it's pathetic. I mean, the minute you hear anything that's less than thousands upon thousands of people, just ignore it completely. I mean, you can sort of say it's fruit for further investigation, but and I don't know if I've asked you to read this, but there's an article. It's probably further on in the class. There's an article by Jan Ioannidis. He's a professor, he's a physician, and he's a professor of like biostatistics. And he did a study in 2008, I want to say. It's a seminal study on the fact that 80 to 85% of all the published literature in medicine is either invalid, not statistically significant, or not reproducible. So there's stuff that we are going around talking about, including me, that we will find out that it's not reproducible, it's not statistic, it's biased, and it's not valid. And if that's 85% of what we do, that's pretty telling, because we're supposed to be doing things based on data and science. But if 85% of the data and science that we have is either biased, not reproducible, not valid, is statistically inaccurate. And do people think that bias is a huge problem in research? Yeah, it's enormous. And if you do a study that shows no benefit of something, of what you're querying, and it's negative, how likely is that to get published? Versus something that shows an amazing impact. So all these people are based on their, get publications and get funded based on their publications and how many views they get and whether it's considered, great research. But negative studies frequently just get ignored. And there's a great TED Talk about how when all you show are positive studies, one, it completely biases the researchers to just give you positive results. And then two, you never hear the negative results. I mean, if a pharma backs a particular drug and they do 10 studies on it and 9 show that the drug does nothing, but 1 shows some improvement or benefit, which is the one they're going to promote and try to get published? And you've never heard of the other 9, just the one that shows a positive impact. And that's why there's so much bias. I mean, literally, please don't believe anything. If something I say sounds suspect and you don't believe it, research it and query it. Or during the course of doing your papers, you read something and you're like, really? That doesn't make any sense. But the reality is that you should question everything. Sort of always verifying and checking sources is just crucial. So yeah, I think that's really important, and especially with nutrition. As a matter of fact, Ioannidis, I should find that article. Ioannidis did a whole review on nutritional research and said that like literally 95% of nutritional research is complete crap. And it's very hard to do randomized double-blind controlled studies. These are all cohort studies and retrospective studies when it comes to diet. So it's a very difficult, incredibly difficult topic. So we've answered question 3, how important is nutrition in maintaining good health? Critical. We've listed tons of diseases that are related to nutrition, which probably is way over half of what we spend on healthcare. I mean, way over half, probably 70 or 80% of the diseases that we mentioned, whether it be cancer or orthopedic problems or diabetes, account for overwhelmingly hypertension, cardiovascular disease. I mean, cardiovascular disease and stroke is the #1 cause of death in the United States. Number 2 is, I don't know if COVID is kind of bumped up those numbers pretty dramatically. And number 3 or 4, matter debate. Some of it is pulmonary diseases, but a bunch of it is actually medical errors. There's a bunch of studies showing that medical errors are one of the top 3 or 4 causes of death in the United States. So a really important topic for public health. And then same question, in addition to diseases related to nutrition, medical complications of overweight/obesity. So we already answered that question. And we've already answered the last question, which is get an overview of the Geisinger pharmacy program. Is this a cost-effective spending for healthcare system? And so we already talked about it's cost-effective if we had a wellness program and we wanted to decrease our overall budget for spending on healthcare, because we'd be spending the money for wellness and keeping people well, but we don't live in that budget. I mean, if the federal government was deciding how we save money, the federal government would spend all this money on good nutrition because their overall budget would go down and hospitals would go out of business, which is great. Thrilled for doctors and hospitals to go out of business because people are healthy. It's kind of paradoxical, but think about it. Both doctors and hospitals and the whole entire healthcare system is not particularly happy if disease rates go down dramatically because they go out of business or they have to downsize dramatically. It's really just a paradoxical and sad system, and why there's so many failures, because every system is perfectly designed to succeed within the rules that they have, and the rules that we have are get sick, come to the hospital as frequently as possible, get as much surgery as possible. That's what keeps the system going. Anything else on the readings? I'm just going to look at the rest of the readings that we had. So those were the questions which we've all answered. I'm just going to try to see if there's anything else in the readings that I wanted you to focus on the nutrition side. Pharmacy, Central Food Bank. And then, I gave you articles, one on bariatric and one on food insecurity as a risk factor for cardiovascular disease. Any thoughts on the bariatric surgery article, and any comments on the food insecurity as a risk for cardiovascular disease? Let's talk about the bariatric surgery. What was sort of the conclusion of the bariatric surgery article? Is it good? Is it bad? Is it a great way to treat obesity?
That mortality was lowered significantly for like 1-to-1 comparisons.
Yeah, no, it's fantastic. Reduced all-cause mortality was durable for multiple decades, for multiple bariatric surgical procedures for females and males, greater than age 34 years at surgery. Rate of death from suicide was significantly higher in surgery versus non-surgery participants, only in the youngest age at surgery participants, which is actually an interesting piece of data. What's fundamentally flawed about since it definitely lets people live longer, what's fundamentally flawed about the whole concept of encouraging bariatric surgery, including the fact that there's many people who propose bariatric surgery for children, adolescents, which is pretty shocking, but it's true. If it's so great, why isn't everybody getting bariatric surgery?
Because there are so many complications you can have from it.
Oh, there's tons of complications, and
It doesn't.
And what again is the concept of bariatric surgery encouraging? I get boring over time.
Encouraging like a thin society, is that what you're?
So no, I mean we want a thin, at least we don't even care if they're thin. We just want them to be normal weight. So a normal weight society is the goal. But do we really need to have everybody who's got a BMI of 30 or higher to be getting bariatric surgery? I mean, there's tons of interventions short of major invasive surgery, even if it's laparoscopic, to address the problem. I mean, the thing is, we don't have one quick solution. Anybody read about any drugs recently that are being proposed as potentially beneficial?
Isn't there the one for diabetes? It was like, it started with an O or something.
Perfect. Ozempic. It's also known as not Morzoka, something with a W. It's just a different dose of it. It's the exact same drug. It's Ozempic. So I'll speak to you from experience with it. So you're supposed to lose anywhere from 12 to 30% of your body weight. It's supposed to suppress your appetite. It's injectable once a week. I used it probably 3 or 4 months. Did absolutely nothing for me. And I just went back to Atkins and again, lost 35, 40 pounds, still have a ways to go. But what's the problem with the drug? Does anybody know what happens when you go off the drug?
It comes back.
Yeah, exactly. Surprise, surprise. Here we go. Yo-yo dieting. So it's just, do you really want to put, and what percentage of the population is overweight in the United States? Oh, do you want me to do the poll thing? Like 10%, 20%? Yeah. So 10%, 20%, overweight, not obese, overweight, 40%, 50%, 60%, 70%. Okay, everybody gets A+, it's over 70% are overweight. What percentage are obese? 10%, 20%, 30%, 40%, 50%, 60%. So overweight is 70 to 80%. Obese is in the right around 40%. So if somebody told you 50, I'd say that's a little high. Somebody told you 20, I'd say that's definitely low. So it's somewhere between that range. But this is an epidemic problem. And it's a very complex, there's no simple solution. So are there people who are addicted to food? What's the biggest problem with being addicted to food? Why don't we just put them into a 12-step program?
Unlike, with other, like with substances, for example, you can't just not eat.
Yeah, so there's no such thing as quitting cold turkey. There's no such thing as quitting eating. You have to eat. So you have to develop a nutritional plan and diet. And when I say diet, I mean your eating habits have to then resort to some level of moderation. And we've talked about it in previous classes. Why is moderation so hard in our society? Other than we've talked about big portions at restaurants and stuff, but more importantly, that the food industry is just jamming down our throats, literally and figuratively.
Because the foods, they try to make it addictive.
That's exactly right. Their incentive is to get you to eat as much as possible. They don't make any less money. I mean, I guess they could do the calculation. If you die early, you're not buying their product anymore. But the reality is, they want you eating as much as possible and buying as much of their highly processed, highly addictive, and satisfying foods, because that's how they make billions of dollars. So it's sad but true. That's kind of, I'm trying to see if there's anything else. And food insecurity is a risk for cardiovascular disease, no surprise. So I just threw that in there just so that you can see that the disadvantaged and are once again become victimized in this system. So that's it. We got 5 minutes left, and I'll use the 5 minutes to ask if you have any further questions. Please email me if you want to chat about your topic and narrow it down. Please submit all your questions. The sooner the better, because you have all the answers now. So there's no reason to say, oh, I didn't get to the questions. We literally just went over them in the last half hour. So get those in. It's 40% of your grade. And I just want everybody to get the full credit for all these questions. And you should get them, because we talk about them in class, you should get them all right. Try to expound a little bit more. So I know, yes, no answers or one word answers are not always as well received as a couple of sentences. So if you can spend an extra, 5 minutes and put together a few sentences, like you actually listened to me in class or found something interesting in the articles you read, that just makes me feel like I'm more successful getting the information across to you. Trying to think if there's anything else. Yeah, anything from you guys, questions, issues? Not all at once now, please. Okay, great. So that's fantastic. Terrific class. We'll talk about gun control. We'll obviously do our standard update. Oh, the one last thing I will tell you is when you do your update, you can just give me one topic in Kaiser Health News. You don't have to do multiple, one's fine. And if it's something we can talk about for a couple minutes prior to moving on to the next person. But with regard to your papers, I don't mean to be paternalistic, but at the same time, I want to hold your feet to the fire a little bit. When you give me your update on your paper, I not only want the topic, but I want you to give me one resource that you read that had an interesting fact that you didn't know. So you're educating everybody in the class as well as yourself. And I'm holding your feet to the fire to say, I want one new resource every time. Oh, Keisha, we didn't mention your IVF implications of Dobbs, but I know that's your topic, and there were some excellent talks on it, which I sent to you by Glenn Cohen, and I would talk to him on the phone. He's brilliant. The guy's he's at Harvard. He's at Harvard Law School and runs the Petrie Flom Center. Do people think I send out too many announcements? I try to send out stuff that you can just delete, especially if it's a topic you're not interested in. But a lot of times there's interesting free lectures, and if it's a topic you're interested in. But if you want me to sort of take you off the interesting topics or lectures list, I'll just send you stuff that's mandatory for class. Anybody want me to, because you can just delete them as soon as you see them. That's not of interest to me, click on. But if you don't want to, if you're getting 1,000 emails a day and you want one less, I'm happy to make you my one less on elective topics. Feel free, you're not insulting me. You guys are busy, you're juniors and seniors, you got a lot on your plate, so no worries. Okay, all good. Thanks for everything. And on Thursday, I just one article, spend an hour or two doing some research, read a couple of articles, and find a particular fact that interested you about your topic that you didn't know before, and we can maybe all learn something in class as we move forward. Thanks for everything, guys.
Thank you.
Miguel,
Thank you.
Yeah.
take care.
Thank you.